Thomas. So we move on with the discussion now. So it's time for questions for the audience and also for the chat. Well, Sahid is going to the mic.
Hi, thank you. That was a great session. I have so many questions, really, but I'm only going to ask one. And I wanted to raise a topic that we just don't talk about. We've spoken a lot about secondary care, specialist care. And I wanted to ask really the whole panel, because we have a very international panel here, and also the audience, about primary care, because the vast majority of cholangio patients will be processed through the NHS. In the UK, we have a system where you cannot access a specialist unless you go through the GP. And GPs are really tasked, and they're actually called gatekeepers, because their role, whether they admit it or not, whether politicians say it or not, is to reduce the number of people going in. My brother is a GP, I have many family and friends who are GPs, and they can't even refer, actually. If they want to decide they want to make a referral to a specialist, it now goes to a panel, the local commissioning centre, who say whether they can refer to a specialist or not. So the purpose of primary care, actually, one of its purposes now in the UK is to prevent people being referred to specialists. And I think that's a really important issue when it comes to cancer. And I just wanted to get a feel of what people thought about that, and also what the situation is in primary care in other countries.
I can respond from Italy perspective. There is no really rules. It depends where you are at local level. If you are in an academic hospital, you can access to NGS, and usually this patient are just managed within hospital, not by general practice, just by specialist, oncologist in particular. I am a good experience with my oncology colleague that we see patients together, and we are very lucky to have an academic hospital which perform NGS actually paid, reimbursed by the government, by the public health. But as you see in the virtual mobility grant that Raffaella Casalino is proposing, is indeed to try to understand what is the situation in Europe with the access to molecular characterization and also to the target therapy, because actually in Italy we don't have approval by the National Food and Drug Administration in Italy of the target therapy for cholangio, neither EDH1, neither FGF2. Hopefully we will have very soon this. So I think there is the need of understanding what are the different, and I think that there is an important also need of do lobby in this respect, because of course probably in Netherlands there is a very virtuous approach, for example, for a very cost drugs, but in the rest of Europe it is not so. So there are many implications. So I think there is a need of a strong convergence of interest to impact, because at the national level it will be very hard to have this drug reimbursed for our patients.
If I may add, the Netherlands, I mean, we're talking about GPs, yeah. So the Netherlands has a very low threshold to get primary care, and it's the same. So we only primary care, so only GPs can refer to hospitals. So there's no difference, and I think that when you call your GP today, you can get an appointment tomorrow. That's not the problem.
Are GPs penalized for referral? Are their referral patterns monitored?
Not at all. No, not at all. So that's not the problem. But as you see, as I shown my numbers, I'm afraid this disease is so acute that I don't know if that is changing anything. I'm just not sure.
Yes, and in France as well, the trajectory of a patient from primary care to specialized teams is not so strict as in England. The GP can refer the patient, and they are not the number of patients they are referring is not counted, and so they are not penalized if they refer too many patients to specialized care. So the thing is that if the patient wants to be reimbursed for its consultation with a specialist, he needs to consult first the GP. That's just a financial thing in France. But also we talked about the lack of awareness about BTC in general hospitals, but it's even more pronounced, I think, in the primary care setting. So we want to increase the awareness and the knowledge about the different therapies in oncology specialists, but we also have even more work with GPs about this disease, I think.
Thank you very much. I would like to ask a question to all the panelists. It is very good that during the last years, different national guidelines has been published and promoted, and also international. Now the question is, which one should we follow? Because most of them share many aspects, but there are some discrepancies and some concerns. So we're in a European Union or European level, but every nation
do we
guidelines.
know how these national guidelines actually are
Generated.
How they're funded, how they made? Because the system we have is quite expensive. We spend about 100,000 euros for each guideline, and so we have like independent organizations who do the research. We do the PICOs, and they do the research, they do the summaries for us, and we discuss it together. And so then I think it's well spent money, but I don't know if, let's say, I don't know how the ESMO guideline is done. I just don't know. Do you?
No, but I think, there are now ILCA guidelines, ESMO guidelines, French guidelines,
But I think as well that these guidelines are important for us to discuss with our regulatory authorities, and that's why we need this translation, because for the methodology, for us it's a fully academic initiative, so we have no funding at all. But the methodology between the TNCD, it's an expert panel saying what they think based on the literature. The AFF, they did a Delphi methodology with several rounds of literature review. It was very painful to do these guidelines, but so it's a different level of evidence. But then what we wanted is to state as experts in the field what we think is good for our patient in France, and for example, to do lobby to get access to targeted therapies from the second line setting. And so we know that our guidelines in French will not be expanded to other countries, but so it's more a tool for lobbying, I think.
Yeah, Jesus, you are right that there are different levels of implication in guidelines. First of all, the methodology. The most strict are the UK, I think, because NICE is the most strict methodology with the grade. The ES has Oxford. Oxford methods is not as strict as the NICE one. So this is a first matter of a problem. But then an important issue, for example, in Italy, to have a guideline applied in the national health system, you need to apply to the national health system board that recognize your guideline. And luckily, this approach is very methodological strong. So you can apply only if you have the grade criteria. So yeah, it is hard to follow, especially in a setting like cholangio. I realize that when you want to do a guideline on cholangio, you start already and you are late already, because for target therapy, for example, is unbelievable. You start to do your guideline, and when you come out is very old. So it's very hard to respond to your question.
Final question, please.
So I guess I can talk about guidelines. I think Juan and I both did ESMO. We both did ASCO, and I've also chaired two NICE guidelines committees, and there's a radical difference, obviously. I mean, I think NICE guidelines is very much similar to what you discussed from the Netherlands. As a team, they work on their literature. It's very precise. And it's very expensive, but they're meticulously done. It doesn't mean that when they're done, they're free from controversy. Often quite the reverse, actually, but that's a different story. When I did ESMO, I presumed that somebody in the centre would do all the literature review, send it to all of us, and then we would be able to work on that, but absolutely not, nothing like that. It's based on our own expertise. But I think it was reasonably quick, and in fact, it's got you know a lot of the new agents actually in it. Juan, is it not? So I think it's a reasonable way of doing it without spending the vast amounts of money that you spend with NICE. And I would commend it to you. I think it's going to be very good.
Thank you very much for your comment. So we came into the end of this session. So I want to thank all the panelists and the audience for the question and discussion.